Hello everyone and welcome to another SDF COVID-19 webinar. The title of today's webinar is Lessons Learned and Challenges with Easing Lockdown, People with Drug Problems, Public Health and COVID-19. I'm Dave Liddell, CEO of SDF, and today we'll be focusing on what the future challenges are for public health and people with drug problems as restrictions begin to lift. This webinar is particularly timely as the Scottish Government begins its rollout of Test and Protect today across the 14 health boards. We're delighted to have three speakers today from across Scotland. Joining us are Trevor Lakey, Health Improvement and Inequalities Manager, NHS Greater Glasgow and Clyde, Emma Fletcher, Public Health Consultant, NHS Tayside, and Claire Glen, Senior Health Promotion Specialist, NHS Lothian. Each speaker will give a 10-minute presentation, then we will have a question and answer session at the end. Attendees can submit questions throughout the webinar. The Questions tab appears on the control panel, which should be on the right-hand side of your screen. Austin Smith, my colleague, will join us for the discussion session at the end of the presentations, and he will then summarize the questions being asked by the webinar attendees, and then I will pass those on to the speakers to respond. So without any further ado, I'll hand over to our first speaker, Trevor Lakey. Over to you, Trevor.
Good afternoon. Thank you, Dave, and good afternoon to everybody. Got the technology working well, I think. I'm going to take you through my 10-minute piece, and I've actually got a working title for it. I'm going to look mainly at the public health dimensions of some of the drugs issues of the pandemic so far. I've got a little working title which I'm going to share with you, which is called Keep Riding the Bike While Learning to Surf. Let me explain that to you. So I want to imagine a scenario of cycling along a path as our main duty to provide supplies to a vulnerable, isolated community at the end of a coastal path, but the storm arrives. So how do we keep providing that vital service during the storm? But my learning to surf bit is just a thought which I'll come to at the end of how do we then not be entirely focused on the storm and look out to sea and to see if there's a tidal wave coming. How do we think about some of the longer term implications of the crisis that we're in as well? So got three main chunks I want to talk through. One is gathered from a range of colleagues, particularly my colleagues and my team, Joe McManus and Graham Matthew, who've been working with me on this. What are some of the kind of rapid modifications of services that have been going on in the drugs and allied fields over the last challenging few weeks? So a few examples there I'm going to draw on. Second piece on some of the intelligence gathering and a few examples from Glasgow and surrounding areas. What changes have we had to try and make to bring in intelligence when some of the normal systems have been challenged? And the third brief piece will be a quick thought about some of the longer term trends and challenges that might come from the crisis in the broader sense. What impact might that have on the drugs area? So three main headings. Back to the first one of those, and all I can do is give you a little snapshot and a flavour. Really helpful in some of the comments and questions that other people are sharing their experience of what they've been adapting. And again, I'll rattle through at some speed. So one example, which I'm sure has been happening in many areas, has been in the harm reduction area. Certainly in Glasgow, a whole range of efforts have been made to, for example, such as mobile facilities with backpacking to support very vulnerable groups. In Glasgow City, that looks like a group of around about 500 to 600 people. So some of the services we're providing, needle exchange and the lock zone, information and support to people, and signposting to a whole range of other services and supports. And certainly one of the things we've been hearing from that is a lot of isolated and vulnerable people with significant mental health issues as well, but able to help link people into a range of services and supports. On the information front, a whole range of activity underway. I'm sure that's true across Scotland, both letting a whole range of agencies and groups know what drug and alcohol services are available still in the changed circumstances. Certainly a lot of work on mental health as well. So we produced in our team a range of mental health support information, suicide resources and so on, suicide prevention resources. And they went out to drug services as well. I'm going to give you a flavour which has been gathered by my colleague Graham Matthew, and thanks to the two agencies he's been linking with this last couple of weeks for a few examples of retooling at speed, if you like. And that's some of the work that we are with you do with the recovery communities in Glasgow, and having to at speed reshape a whole body of services that have been traditionally done in face-to-face ways. Certainly very interested to hear other people's experiences of this, and if there are people from we're with you and GCA, my two examples on the call. It'd be great to hear some of your thoughts as well. I hope I'm doing justice to you. So things like daily check-ins using Facebook and Google Meets, using Zoom meetings for support groups and so on, online Zumba classes, quizzes, bingo, and a whole range of supports of that kind. So a huge amount of effort going in from staff and from peer groups and so on. GCA, quite similarly in Glasgow, doing very similar things, responding at incredible speed. So telephone counselling, one-to-one supports, using the GCA helpline with an experienced counsellor on the line, being able to support additional support to vulnerable clients such as food packs, top-ups for phones, arts and craft activity packs for kids, providing telephones and tablets to clients and so on. So a huge effort underway from many areas. Another example from the broader city response has been food packages to many vulnerable groups, including the prisoner release program. So again, a huge amount of effort going into galvanizing all of that. And the final example I'm going to give of this sequence is actually an attachment in your sidebar, I think. So Joe McManus in my team, the Health Improvement Lead for Drugs, is part of the Eurocities network on substance misuse. They did a rapid exercise around the participating cities in which Glasgow is an active member of, particularly during the month of April, what some of the rapid reactions to services were. So if you're interested in that, you can click and download the PDF, I think it is, in your sidebar and look at that in some detail. So I won't describe that, but again, great to see around the continent, huge range of imagination and effort going in to respond to needs in the most difficult of circumstances, with physical access to services being disrupted. Moving on to kind of my second piece, again, very, very briefly, and I can't do full justice to this, you'll understand. Again, Joe McManus in the team has for many years overseen something called the Greater Glasgow and Clyde Drug Trends Monitoring Group. But in the circumstances, a whole group of colleagues were keen to get additional intelligence, given the disruption to certain systems and services. And what's been put together is a range of things under the non-fatal overdose intelligence gathering system. I won't try and describe it all in great detail, but it's using a range of contacts and some pro formas around non-fatal overdose incidents, but connecting with partners to get the idea of soft intelligence. This is not named personal identifiable data. This is the kind of data coming back from frontline staff, from police, ambulance service, emergency medicine, homeless organisations, purchase services, and so on, and clinical leads in a range of teams across the whole health board area. And I can't do full justice, as you can expect, in 10 minutes, but just some of the themes coming through from that. I'm sure that this will chime across other colleagues' experiences. Concerns about methadone, about overdose and withdrawal issues, debt and crime dimensions. Are people building up debt because the normal routes of gaining finance aren't available? A big theme about more obvious mental health difficulties emerging from a lot of client groups. Isolation, family tensions, and situations of during the lockdown of families where previous unknown drug misuse has come to light and causing considerable difficulties. And again, any interest to hear any further comments on what local intelligence has been like. And finally, just a brief few thoughts about that, the kind of what's the wave coming from out at sea, if you like. What are some of the bigger, longer term implications of the crisis that we should be thinking about as a public health body of work? And it's been good to see, both in the mental health and addictions areas, quite a lot of academic work going on. Some of you will have seen the £5 million rapid research pot that the Scottish Government put out, quite a few addiction-related ones in that sequence, including Stirling University looking at the impact of the pandemic on people who use drugs, a whole range of others. So how do we draw from all this ongoing work? If you're interested in the mental health area as well, there's something called covidminds.org, which is an international gathering of mental health-related tracking surveys. I'm sure there'll be quite a few of those that look at addiction issues as well. So a lot of those studies, but how do we draw from that at speed and look at some of the potential impacts? What are some of the things we might anticipate around, for example, child trauma, children and young people being drawn potentially into very vulnerable situations, grooming and all the rest of it. The huge evidence around the impacts of mass unemployment and poverty increasing. So how might we model some of those issues impacting on drug issues in Scotland? Voluntary sector and public sector finances will be huge unknown for the considerable period of future. So how do we think about how those issues might impact? What's our predictive work, anticipatory work around the drugs impact of the crisis, not just for the next few weeks as the lockdown starts to ease, but in the months and years ahead. So that's my 3 big themes. Hopefully that makes some sense to you. In conclusion, huge effort around the country to respond to the crisis, of retooling, if you like, and thinking imaginatively about how to support vulnerable groups, not without its major challenges in terms of digital access, in terms of staff skills and policies and equipment and so on, but a considerable success and a lot to be proud of around the country in that, I would say. How do we adapt our intelligence systems to gather intel when perhaps some of the normal regimes aren't in place so well, and be able to respond at speed if need be to emerging issues? And then finally, making sure we have some time and energy devoted to the longer term thinking and planning. What might we predict major increases in unemployment and poverty and so on will do to longer term drug trends? Thank you very much.
That's great. Thanks very much, Trevor. Our second speaker is Emma Fletcher, and we'll go straight on to Emma. Thanks, Emma.
Thanks, Dave. So for someone who's shied away from any digital presence, this is somewhat terrifying and very much a first for me. But all work around substance-related harm, and in particular drug deaths, is so very important, and even more so in this time of COVID, that I am very, very grateful to SDF for this opportunity. Thank you. So I just want to start by thinking of the whole system approach to reducing substance-related harm, and in particular drug deaths. This is a representation of a poster that sits on the wall right behind my computer in my office, and is a reminder of the whole context in which we are working. I made it just under 2.5 years ago when I first came into post, and I look at it often to think and reflect on all the various aspects where we could and should be levering to make change for the better. And then this is the same diagram, but in the context of COVID, and considering the impact of COVID across all of these areas is massive. The 2 main areas where it is impacting most at this stage is around communities and service delivery. In communities, it is impacting the environment people are living in, affecting employment, security, support, hope. There's no longer the same variety of safe spaces that people can access or escape to if needed. And support structures between friends and extended members of the family have been significantly disrupted. With service delivery, most of the change concerns how services are now delivered. Whilst key substance use services are being maintained, the requirement for social distancing now means the way in which these are delivered is significantly altered, and routine, non-urgent work has stopped. And then to a lesser extent, it's impacting on service improvement, continuing service improvement. The traditional ways in which we're doing this has stopped, but there has been and continues to be a significant opportunity to look at and consider the ways in which we are working and responding to the challenges of COVID, and look at new innovative working and collaboration across organisations. And similarly, I'm the chair for the Tayside Drug Death Review Group, and our case review process for when a drug death has unfortunately occurred is ongoing, but again has been impacted in some respects. There are 4 main ways in which the risk of drug death has been impacted in this time of COVID. Firstly, there is the direct risk from COVID-19 infection, particularly given that people with problem drug and alcohol use often have underlying health conditions and may find it harder to socially distance at times. They are therefore in increased risk of transmission from the infection and subsequent harm. There is the risk of disruption to the supply of drug or substance that a person has taken, including leading to withdrawals, substituting substances, and potentially also increased substance use to self-medicate mental health concerns that are arising as a result of lockdown and increased isolation. There is a risk from disruption of health, including prescribing and dispensing arrangements of medication in both primary and secondary care, social and third sector care provision due to the social distancing measures that are required to be implemented. And there is this risk from what we term excess mortality that is being seen across the population during the time of the pandemic, the causes of which are not fully elucidated and understood as yet. In my role as the Tayside Drug Death Review Group Chair and Consultant in Public Health, I'm really keen to keep a really close eye across to these particular risks at this time. So in terms of the COVID-19 infection, we have had confirmation that people who have sadly died as a result of a drug death are being tested for COVID-19, whereas it's suspected as a contributory cause. But most importantly, we need to also think about how to support people who are in the community and alive and well before death occurs. And we very early introduced community testing in hostel settings where there were concerns about possible COVID-19 infection. And approximately 2 or 3 weeks ago, we also introduced community-based testing for all people with problem substance use, drugs or alcohol, who are reporting symptoms of COVID-19. In terms of drug trend monitoring, there's various ways of doing this and also variability across Scotland, which at some point it would be really good to get standardised and considered at a national level. Similar to COVID-19, there can be testing at post-mortem, but as we unfortunately know, there is a bit of delay in the results being returned at the moment. But also there is inconsistency as to what substances can be tested for and by whom and people presenting to clinical services, and that would be really useful in future to strengthen and get more standardised to tailor the harm reduction messages to be reactive to specific emerging threats. In terms of local care changes, I understand that Public Health Scotland are now liaising with Police Scotland and getting kind of live updates on suspected drug deaths across Scotland, which is excellent. And whilst that information can't be shared at a board level at the moment, it is really helpful to me as a consultant in public health to speak with national colleagues and to understand the current situation across Scotland and where we are and to contextualise that. And again, with regards to thinking about this term excess mortality, that needs to be considered at the national level and would be contrasted across to all deaths at this time. So those are the 4 areas that I'm particularly keeping a really close kind of eye and focus across in terms of trying to understand trends, look at trends, react very quickly to what we are seeing. In addition, I do just want to highlight, next Sophie please, that we're also very cognizant of the wider task force recommendations that are all available online. Those are the main areas, and also the SDF guidance that has recently been published also. So talked a little bit about overall trend monitoring, but I also, my team are very alert to potential clusters where targeted public health intervention may be required. And these are identified by Police Scotland and Public Health Drug Death Coordinator working very closely together. And they raise concerns to me if there are an increased number in a particular time frame. And to look at this, I then usually use a kind of a health protection framework to essentially risk assess the increased incidence, looking and seeing whether there are particular commonalities between the fatalities that have occurred, and look in particular at these parameters. And then this guides the risk assessment, be it COVID transmission, alteration in substances, or some other factor. And I try and get a very good quick overview as to what is happening to then inform a dynamic response. And we monitor also any trends and clusters in the context of the non-fatal overdose information that we're getting through from colleagues to look at those trends together and to see how they are changing and whether they are changing in parallel or whether there's differences between them. Thanks, Sophie. In terms of where our trends are currently, this graph shows the cumulative number of suspected drug death notifications for Tayside month by month for the years 2017, 18, 19 and the start of 2020. There was very little variation between 2019 and 2018 in Tayside in the notification of suspected drug deaths. In 2020 thus far, we are mirroring those trends of previous years, which I understand from national colleagues is the broad picture across Scotland also. And whilst it is of some reassurance that we haven't seen a spike following lockdown, as some other places have elsewhere in the world, it is absolutely still not where we want to be in terms of the number of people who are dying as a result of a drug overdose. Next, please. In terms of thinking forward, looking forward to easing lockdown, it's going to be a very dynamic picture. The risks will change depending on level of community infection, the requirements of the social distancing and the other public health measures that are currently implemented for COVID. And there are significant additional risks that will be coming. There will be the significant economic impact, which thus far has been largely mitigated, but is of significant concern going forward, and the effects that is going to have on our communities. So just coming back to the last slides that I'm referencing back to the beginning of the presentation. So whilst this organogram may broadly stay the same in content, there will be different contexts and new ways of working across the piece that we have to adapt to, but also seize the opportunity to continue to advocate and make change for the better for people who are experiencing problems and challenges with drugs. Thank you.
That's great. Thanks very much, Emma. Can we now go to our final speaker, and then we'll move to questions. Can I introduce Glen from NHS Lothian? Thanks, Claire.
Hello, everybody. Thanks very much. So, yeah, my name's Glen, and usually as a day job, I am Senior Health Promotion Specialist working in public health with a remit for drugs. But since the beginning of COVID, I've been redeployed into our COVID response team, so my jobs look quite different recently. This should help to give a bit of context for what I'm going to discuss today, because my discussion's a wee bit different to what's just come from the two previous speakers. Initially, I was supporting health protection and general support once COVID started, but then once homeless people and people who use drugs were identified as priority groups, my work changed there. So today I plan to provide an overview of some of the work that's gone well in the homeless services and with the homeless population in Edinburgh, and particularly the parts that we can replicate and apply to the community settings with people who use drugs and other services, and then finish by highlighting some of the newer challenges that we face and how we're going about tackling this. Okay, so both speakers have already highlighted the risk of people who use drugs are at in terms of contracting COVID because of lack of social distancing, certain behaviours and other vulnerabilities. So when we started the work with the homeless accommodation, we were aware that with all the rough sleepers being brought in, there was a big risk, and large numbers of people being brought together, there's a big risk of a potential outbreak. So we needed to support staff and services on how they could deal with that in the event of any positive cases. So a small team was brought together to do this. We did all the mapping, did visits to plan for infection control and isolation spaces, and we developed a checklist. So the checklist has covered issues around preventing and controlling COVID-19, and covered things such as prevention and preparation, so risk assessment on entry to the building, measures that people could put in place to reduce any risk, sort of increasing hygiene practices and things like that, how to respond to a case if somebody was symptomatic by isolating people straight away, finding spaces to isolate them, and then the follow-up process with having them clinically assessed and obviously contacting public health. The public health assessment would be looking at ongoing isolation, the exposure of risk for other people, and the need for testing. And then there was other advice around cleaning, useful contacts and other guidance. This checklist proved very successful, and it's felt that this is something that could be adapted for use in substance use services once we start to look at remobilisation of services. It also links with some of our work that we've done around our enhanced outbreak response team, whose purpose is to control outbreaks in closed and shared residential settings. So they've been working in mainly care homes, but obviously there's been some potential cases in hostels, which thankfully have never come to anything. But the whole point of that team is that they can test either staff or service users and do it quickly to try and reduce the risk of outbreak again. So these are all things that we can potentially apply to substance use services. I think I can echo what's probably been said in a number of webinars already, that multi-agency working has been amazing during the pandemic. I've never had so many people's mobile numbers, so that's been great for a start. whilst we did the work in the homeless settings, we had more outreach done into the settings where it was easy to actually reach the most vulnerable people whilst they were being housed. We had our sexual health team doing outreach. We had our community vaccination team who visited the hotels. They provided routine vaccinations such as tetanus boosters, MMR, diphtheria, tetanus and polio, and also Hep A and Hep B. This has developed great links for the future vaccination work for monitoring and follow-ups, and also with the relevant services. But it also highlights the need to enable better access to vaccination for people who use drugs, including flu vaccine, and also hopefully open up similar routes for the vaccine for COVID. We also did some good work with the smoking team. So we know that there's increased risk of respiratory issues amongst people who use drugs, and we were able to secure funding to provide vapes for people in all the homeless settings. We worked with Streetwork to coordinate this, and it's been really quite successful with over 200 vapes being distributed. It's provided multiple benefits, but it was initially intended to support self-isolation and improve social distancing. So part of the checklist that I spoke about earlier was about how people's wider health and social care needs can be met on top of once they were having to self-isolate. So initially, getting the vapes was intended to support self-isolation and improve social distancing. However, it's also been beneficial in reducing risk from people sharing cigarettes and making cigarettes from cigarette butts. It's been proven popular with heavy smokers and those previously unable to afford to try them. And Streetwork are reporting that it's had an impact on all of these things. It's also, so in terms of moving forward and how we're working with people in drug services and people who use drugs, this has provided a foundation for further work that we've got planned for later in the year to look at the provision of vapes for people who use drug and alcohol services. I suppose as we're moving out of lockdown, there's potentially a number of challenges. Emma and Trevor have already discussed in terms of drug-related deaths, changing drug trends, access to services, unemployment and financial problems, and actually contact with service users. So throughout the pandemic, our CHIN team, which is our team of analysts, have continued to look at surveillance of key data to indicate any changes in uptake of services or any key trends. Once we start to look at reconfiguring services, I suppose a challenge will be how we resume some previous provision where possible, but also making sure that services are supported and have capacity and resource to maintain the innovative work that they were doing as a result of the pandemic. There's some elements that we were trying to start off before the pandemic hit, but that was accelerated massively once we got into COVID. So things like rapid access to ORT, assertive outreach. It's also essential that we are ensuring that we reach the most vulnerable people who fall through the shielding categories and the very vulnerable categories as well, because there's a number of people who use drugs who don't fall into these categories but are still in need of greater support for additional support needs. I suppose for the time being, going forward, everything will be underpinned by the need to prevent and control COVID. And as we move into the next phase of the test and protect, we need to support people to comply with social distancing even more. We need to start looking at how we do contact tracing effectively with people who use drugs, and this is something that we're starting to look at in Lothian at the moment. What can we do differently to support people who've got past experience of trauma, mental health problems, distrust and fear of passing on any information, which will obviously affect how they engage with contact tracing. So we're currently developing some guidance on this and working with staff to look at how we can support staff and help people to respond positively, looking for ideas how we can increase engagement on this. Thinking about maybe a bit more digital work with people. People are a bit more, people have been provided with mobile phones, so they're maybe a bit easier to get hold of, but it's how we actually get them to engage with the calls as well. So yeah, that's everything I was going to cover today. Hopefully it demonstrates some of the work that we've been doing throughout COVID and how we can apply it to people who use drugs and working with people in drug and alcohol services. Thank you.
That's great. Thanks very much, Claire, and to all the speakers for keeping precisely to time. So it's much appreciated. Can we have the other presenters back on screen as well now, and Austin as well? So we're now going to move into the question and answer session. Thanks for all your contributions, which were really interesting and covered a lot of ground. Austin, what's the, do you have one theme to kick off with?
Yeah, I think the first question is perhaps the most obvious question, which is how do we ensure that the changes which have been positive, that have maybe been initiated or forced on us by this lockdown and COVID, the ones that remain aren't simply the ones that save money, but the ones that best serve the people we're trying to support and assist.
Trevor, do you want to go for that one first?
Okay, good question. And what we heard from some of our dialogue with local providers around some of the changing to online and phone support and so on was sense that some of that remains really useful and not necessarily to abandon all that once the lockdown eases and so on. So it's not about remaining all online, of course, but how do we create kind of a blended environment where people can get the best of both worlds? So I don't think that's about saving cash, but how do you provide a really good quality wraparound service that gives people lots of options about how they get support? I mean, certainly when, for example, I had quite an in-depth chat with colleagues in Bipolar Scotland and the mental health side, we talked about some people actually found the online experience better than the face-to-face one for all sorts of reasons. But I don't know how you guard against the money-saving ethos, but I think if you've got quality standards coming out of this, I think what we're hearing from many areas is it's not easy, is it? And obviously a lot of the staff haven't got necessary kit and training, so there's a lot of investment, I would think, to make some of these things sustainable and high quality as alternatives. But I know myself having lots of IT problems as well, many other people have, that it's not just a press a button and it all works, is it? Lots of issues around digital exclusion which have come to the fore. I know there's money investment around a lot of agencies, as I mentioned briefly, helping people get hold of tablets and data and so on, but how do you sustain all of that? That will cost money. I think actually we probably need to spend more in the shorter term to make some of these things embed in systems as well. But yeah, I guess it's keeping the pressure on that we can't simply abandon some of these innovations when the lockdown phase eases.
Thanks, Emma. Do you want to add to that?
Yes, I mean, I think it's just a case of objective reflections. It's using our tools and how we advocate for change generally in terms of looking at evidence, both quantitative, qualitative also, and being strong and vocal in where you think and you have the evidence that things have been a beneficial change, whilst also being responsive to future opportunities. And I think it's important to recognise that this isn't going to suddenly be a binary change. We're not, lockdown is suddenly not going to ease and we're going to be completely back to as we were pre-COVID. We are in this position for the next many months as we nudge and release our precautions, we monitor the impact, and there is possibility that we will continue in that phase for very well, a few months at least over the next year. So it is a very much an iterative process, and I think it's contingent on us all, as we do with all of our practices, looking and being very objective in what has worked well, what isn't working so well, continuing to try and drive improvement in what isn't so well, and using the evidence where we have it.
Thanks. Claire, do you want to? No.
I think Emma and Trevor have covered it quite nicely.
Okay, that's fine. Thanks, Claire. Austin.
The second question is a sort of related question, and it might be interesting to scope this out, but how do we evaluate the effect of these changes? Do we do that formally, and is there a space to do that? And how do we ensure that the voice of lived experience service users or people using services have a voice in that?
Claire, do you want to have the chance to go first on this time?
Yeah, I think that's a really important point actually, and perhaps it's trying to do something quick and easy in terms of maybe a quality improvement type evaluation. That's the type of thing we're looking at in Lothian, but also getting some qualitative feedback from people who are experiencing the services and how they would see the services developing going forward.
Emma?
So yeah, a mixture of the quantitative and qualitative measures, and looking at the parameters that we're recording as it stands currently, the frameworks that have just been, well, I say just been issued, it was just been pre-COVID in terms of monitoring our quality improvement. But as Claire said, it's really, really important that we capture the information and people's experiences of what it is that we're providing to inform how we develop further and decide on what changes we keep and what we continue to improve on.
Trevor?
Well, there's much to add to that. I echo all those points, but again, I guess something we're very interested in as a team is if there are any colleagues, particularly in the Greater Glasgow and Clyde area, who've been evaluating and documenting some of those experiences of changing services, we'd certainly be very keen to hear about that, and we can support any of that evaluation. I think, as you say in the question, the service user perspective and then the carer perspective is hugely important. So how do we use our pre-existing user networks, but other systems as well to gain that experience? Certainly, I think there's a lot of rich learning right now. I think we're real shame to miss any of that. I think that what worked well, what didn't work well, what bending of the rules needed to happen. Some things certainly a number of us have been pushing on digital health. I've been trying to do for years, suddenly unblocked in a matter of minutes, it seems. But you know, some of those issues will need to be worked through more thoroughly in terms of governance and permissions and all the rest of it, and privacy issues. But yeah, I just echo what I've been saying. I think a really good time if we can find a breather somewhere along the way to capture some of that. I know some organisations will be keeping like daily learning logs of what they've been through. SAMH, I think, does that, for example. So anybody that's got that, I think it'd be a good time to kind of gather and share that in the coming weeks and months.
Okay, thanks. Austin?
Yeah, the third question is a kind of the question that must worry us all, I suppose, is that as lockdown eases, actually it becomes harder and harder to protect people. So although there's a sense of liberation and relaxation, actually this is a time of that people who are at risk are at greater risk potentially. And this is a population who are at greater risk of infection because they find it harder to carry out the advice that's given them in terms of social distancing and so on. And their outcomes, if they do get the infection, are likely to be worse. So how do we create an environment that's safe for the most vulnerable amongst the people we're looking after?
Emma, do you want to go first with this one?
Yeah, I think there are two main prongs to that. I mean, it's first continuing to strengthen and support the assertive outreach that is being provided at the moment, and that is working with alcohol and drug partnerships, it's working with the local resilience planning forums, it's making sure that we know the people that where support is needed, and we're out there in the community providing that. The other big aspect is about testing and making sure that we are detecting infection as early as possible, and then as part of that whole testing and contact tracing initiative, being alert to people's circumstances. And so, for example, here in Tayside, it's the harm reduction team that is supporting the COVID-19 testing in the community. So they are able to go out and support and provide that wraparound care and support for people where there is COVID-19 infection, to enable this, a person to be appropriately supported as they're isolating and their households. So it really is about making sure that we're very quick off the mark in terms of encouraging people to report symptoms, very quick off the mark in supporting that isolation, and quick off the mark to do the testing and feedback accordingly.
Claire, do you want to?
Yeah, I would say continued support as well and everything that Emma said, but also the continuation of the multi-agency working so that everybody's providing sort of a wraparound package of not care but support for people So they're getting the same messages everywhere and as much support as they're getting at the moment, I would say.
Yep. Trevor?
I don't think there's much I can add on the clinical front from what Emma and Claire have highlighted, such as things like contact tracing and making sure that we can follow through on that side of things. Let me add in a couple of other thoughts, which is that I mentioned in my piece. Again, this is material that's come through Jo McManus and her colleagues, including police colleagues, is some of the wider risks that may well emerge, like debt and some of the crime dimensions of that. What are people left with if their normal means of gaining finance have been blocked, and what are some of the consequences of that? How do we anticipate some of that and support as best we can? The other area, obviously, many areas have adapted their homelessness services, of course, at high speed, incredible effort gone in. But how do we sustain that? What happens then? Do people go back to the way they were? And does that generate a whole raft of risks? So again, I think, how do we anticipate some of the knock-on effects of coming out of this phase that are beyond the clinical as well?
And also, it's interesting in the mention of the use of vapes and the provision of vapes, and also that sort of wider smoking cessation. So people have been able to, because they're closely engaged with services, start looking at harm reduction around issues that aren't simply the drug they maybe have the most harmful impacts of their use. So how's that progressing? What does that look like? And what's the harm reduction around vaping? There's some concern from the questioner that there's harms associated with vaping itself.
I suppose because of increased respiratory issues, Public Health England guidance advised on increased use of e-cigarettes, and we know that there is some debate about vapes, but I suppose this was a way of trying to, initially it's a way of trying to deal with supporting people to be able to self-isolate if they were required to, and to try and remove some of the risk from some of the other issues of people not socially distancing. So I suppose in the time of COVID, it was something that was done quite quickly, but as we move forward, we'll be able to do a bit more planning and look into other things around vapes as well. So yeah, sorry, what?
Okay. No, that's fine. I mean, has it been done in Greater Glasgow and Clyde, the use of vapes or Tayside?
I don't have that information, I'm afraid.
No.
I mean, my colleague leads extensively on smoking cessation work, and including all nicotine replacement therapy and the work around e-cigarettes. So I can easily get that back to you after this, Dave.
Yeah. Okay. I guess it's just that, I suppose, wider point about wider harm reduction approaches across all aspects. Going back to your chart there, Emma, I guess, in terms of not forgetting anything in particular. I suppose just before I come back to Austin, one of the questions that was emerging from, say, for example, the homeless session webinar that we had was so far the lack of COVID-19 cases among this population, and I guess that's a real positive, but also, as we've talked about, a huge challenge going forward. Why do we think we've been so successful so far? Claire, do you want to maybe talk to that first?
It's obviously all down to our checklist that I spoke about.
Yes, for sure.
No, it's amazing, really. I'm not sure why it's happened, because we know that they're not socially distancing and lots of people are together, so we have no idea.
Okay. Emma, have you any thoughts?
It's
that is in line
interesting.
with what you've seen in Tayside as well, though, is it? You haven't seen cases?
Yeah.
Many cases.
So yeah, we've been, as I say, providing testing in a hostel setting for several weeks now, and then in addition, I've been testing in the community. So echoing Claire's point, we haven't seen COVID-19 transmission in those settings, and I'm not sure entirely what's driving it. I've got a few thoughts as to why we're seeing cases in other settings, but I think what's really useful and interesting from a kind of public health perspective is as we move through this outbreak and pandemic, is understanding more understanding better the epidemiology of prevalence of COVID-19 infection in the community. So we've been testing people who've gone into hospital, we've been testing in the care homes, but people who have been at home with mild symptoms, up until recently, we haven't been able to provide that testing. As I say, we started that about 2 or 3 weeks ago in people in the community with substance use, but more widely, we don't know what the prevalence of COVID-19 infection is. And as further information and we understand the infection better, and that is shared from, is gathered and disseminated by Health Protection Scotland, that will give us a much better idea. My understanding is the current estimates of infection rates in the community is around of the order of between 5 to 10%, about 7%. So actually a very small proportion of the overall community have been exposed to the infection, and where we're seeing it mostly is what we're seeing in the care home settings and in people who have been significantly unwell and have required hospitalisation. So that's kind of where most of our information to date has come from.
Yeah, thanks. Trevor, do you have anything to add?
Don't think much. I'm not party to any of the detailed testing data, but I don't think I'm seeing anything different really to the trends that Claire and Emma are describing. It's maybe an element of good luck to date. I don't know. There may be colleagues in GTC who can give me much more detail later. But again, as you say, if that 5%-ish estimate is right, then it may be just a case of which population groups have happened to have been the main areas of spread.
Yeah. Austin, any more questions?
The last cluster of questions are around testing, about the uptake, the availability and the uptake of testing, or participation in testing. And also, are we missing an opportunity, or is it actually impossible because of lab capacity or whatever, that we do testing at the same time? So we take a sample and we can also test for hepatitis and potentially HIV as well. There's concern about that whole elimination of hepatitis C agenda being lost because of the pandemic.
Trevor, do you want to go first on that one?
I'm afraid it's not an area close to mine, so I would be unwise to answer that.
Okay, no thanks. Emma?
I mean, I think the most pressing and immediate risk, it concerns the COVID-19 infection, and we have to be really, really on the case with that. I think while as we're kind of moving to a kind of more sustained position as to where we are with this new normal, you're absolutely right. I think we have to pay very close attention to other risks and plan for bloodborne viruses and how we're looking to monitor and reduce any unintended consequences in terms of spread in that area. It's something we're very, very alert to, and with the COVID-19 testing being supported by the harm reduction team here in Tayside, it does provide that opportunity to ensure that additional testing is available and encouraged where someone consents and would like to be tested.
I suppose just in terms of the uptake of tests, there's been absolutely no problem with people taking up tests, but in Lothian we knew there was going to be a drop in sort of BBV testing, so we got a team from the harm reduction team to train people up to do point of care testing, and our BBV teams are up and running again, so they can look at how they can maybe work a bit differently to start picking up testing again.
Before I mute myself with the fact this is the last question from the audience, certainly, is about punitive practices and so on, and some of the criticism that's been made of services over years. Is there a hope that some of that can disappear? And I suppose that the wider picture would be, can we develop a different relationship with the people we work with that's more positive and supportive and a bit more person-centred?
Yep, Trevor.
I think from the kind of weak signals like that we've been hearing of the various kind of intel from all sorts of partners and agencies, seems to be in this real appetite to try lots of different things and to engage with users. I guess if you're offering a service on, say, an online platform and nobody takes part, then you've got a pretty instant feedback that it's not suiting people's needs. So I think I've got a sense of people really rapidly adapting. I think the question up from earlier of how do we learn from the service user perspective in all the innovations that happen is absolutely crucial. Certainly, colleagues have been talking to me about some enhanced partnership working under great pressure. I think you made that point clear as well, didn't you, of mobile phone numbers and so on. So people being forced to collaborate in different ways have really stepped up to the plate. So how do you make that a much more participatory approach? Again, it's maybe making sure there's enough time to pause and reflect before we just hurtle back into the normal system, so that and any kind of efforts to evaluate all that and systematize it would be great. How do we learn from what people actually found was useful, that was different of the current era? What can we sustain? What investment does that need? You can't do any of it for free, can you? If you're going to do service user engagement on a different scale, you need to invest and do that well.
What about, Trevor, in particular, the move away from daily supervised dispensing? Do you have any thoughts on that aspect?
I don't think I'm competent to comment on that kind of area.
Okay. Yeah. Okay. Well, maybe that's. I'll move on to Emma. Maybe if Emma has thoughts on that specifically and the wider question.
My experience is all partners and working in this area have the person absolutely at the centre of their approach. I think what the challenge, and this was kind of pre-COVID as well, is thinking actually about, I mean, all of us who work in this field because we want to make a difference. It's about how we support the wider organisations in which we work, be it whatever sector, to think about what it is, how substance use is part of their work also. They may not think it is. It goes back to that original organogram. It's about thinking how we support people with substance use, because to my mind, we're much better about talking about mental health these days. It's less stigmatized. People will talk about their emotions, they'll talk about when they're feeling low, and that's encouraged. We're still not in a position where we will openly talk about substance use, where we'll openly ask about substance use, and in a non-judgmental way, and have in the wider setting the skills to be able to support people. So I think there is always so much more that we can be doing to really get everyone across the piece to understand the challenges that people with substance use can, not always, but can face, and to be able to build that compassionate, person-centred approach that we should be providing to all people throughout the communities and populations of Scotland.
Yeah, I mean, I was just saying specifically around the move away from daily supervised dispensing, which I think certainly that the user feedback, generally is that has given people more responsibility. Obviously, that's not, to move everyone, because there are vulnerable people that need to remain on daily supervised dispensing. But yeah. And maybe that feeds back to the point about capturing that user feedback. But in lots of parts of Scotland, there's been massive changes to that practice, which certainly, I suppose, our sense would be that would be, hopefully unthinkable to move back, and not take that user view on board. Have you thoughts on that specifically?
I mean, I think from my perspective in public health, it is trying to keep an eye across all elements of the system. I mean, I'm not a clinical prescriber. I can support colleagues in thinking about the relative risks of COVID and thoughts and guidance to consider. But in terms of actually what that decision making is, that is fundamentally for prescribers to make. It's in terms of thinking about what is the best approach. I mean, it will be really helpful and useful to look at how, everyone's experiences across Scotland and look at practice across and see what is working and potentially what is unintended consequences. I mean, we often see that, and that can be quite an unknown, and we see that potentially in some areas elsewhere in the world where some substances have been restricted or other substances have become more available, that has had unintended consequences that aren't always anticipated. So I think from my perspective, it's about understanding the evidence and using that to influence best practice for people.
Thanks. Claire?
Add to what Trevor and Emma have said.
Okay, that's fine. Well, we're reaching the end, and I think we've run out of questions from the audience. So maybe if I just ask you all just for your final comments before we finish. I didn't warn you that I was going to do this, but it's only because we haven't got any more questions left from the audience. So, Emma, do you want to go first, just in terms of I suppose the going forward, just very briefly?
Yeah, I mean, I think my reflections is this is a really challenging time for so many reasons, but it is a huge opportunity to take what is working well, see the dynamic need for movement, and most importantly, and the reason why I'm here today, is making sure that people don't forget how much of a public health priority supporting people with substance use is. And I think that's my fundamental take-home message. Whilst everything else is going on, this is still one of Scotland's key priorities, and I would hate it to drop down the agenda, and we have to keep doing our work and making sure that we're all working towards supporting all our population.
Thanks, Emma. Claire?
It's going to sound like a cop-out, but I was just going to say that I've just written down challenging but opportunities, so I would just echo Emma's what she said about it being a challenging time, but it's given some opportunities to look at new ways of working and see how we can do that from here.
Okay, that's great. Thanks. Trevor, you get the last word if you want it.
Some similar sentiments. I guess my thoughts were the degree to which people in the US have shown considerable resourcefulness and resilience to bounce back and offer all sorts of alternative ways of getting help to some of the most vulnerable groups. My cycling along the cliff in my little metaphor at the start, and as Emma and Claire were saying, how do you sustain all that is crucial, isn't it? And take the best of what we've learned from that. And the fact that you've got some new partnerships and new collaborations coming to the fore. How do we, as one of the questioners was saying, how do we make sure that the kind of participatory approach, the user voice and all of that is crucial? And I guess my final thought would be, this is only the first phase of the crisis in some ways, isn't it? So how do we think long term, as I said in my piece? There's a lot more grief that comes now, let's face it, bereavement issues, there's family disruption, there's unemployment and all the rest of it. So how do we not just do the immediate job in front of us, but think of the big issues that we should be planning ahead for? And as Emma said so well, let's keep reminding folks this is one of the top priorities for Scotland's public health, and all the pre-existing problems are still there, aren't they, that we need to tackle.
For sure. Yeah. Okay. That's great. Thanks very much. Unfortunately, we've come to the end of the webinar, but this has been recorded and will be published on the SDF YouTube channel. We will be sending out an evaluation, and it would be excellent if you'd complete that for us. Our next webinar will be held the same time next Friday, and the topic of the webinar will be on volunteering during COVID-19. A link to register for this webinar will be included in the evaluation email you'll receive. So it would be great if you could join us next week. So finally, I'd just like to thank you for all attending. I think overall is about 130 on the webinar today, so that's great to see those numbers continuing. And a special thanks to today's speakers, Trevor, Emma and Claire, for what has been a very informative and engaging session. Thanks again. Goodbye now.